Is to Dr. Simon and asking, did you assess for attachment style?
In this work, we did not assess for attachment style. One thing I would say is it's been, I think, in the field almost like a little bit controversial or concern that people will overinterpret that only those who have pre-existing attachment type conditions or personality styles that are on, say, the borderline spectrum or narcissistic spectrum develop complicated grief, and that's definitely not the case. But in this particular work, we didn't do that. But I think that is definitely true that there is risk based on morbid or pre-loss attachment. So, people who have had significant losses and later go on to develop, for example, a secure attachment, but it may be like a more of an identity-defining attachment. So, say somebody who had a very insecure attachment throughout childhood, or their parents died, or there was a lot of divorce, so they moved around, and then they finally get settled into a secure attachment. When that person dies, they're at particular risk again. And that's something we've seen clinically, but we didn't do like the attachment styles questionnaire in our particular study, but I know people are looking at that. Yeah.
Thank you.
And another question here.
Hi, I have two questions, one for Dr. Simon and one for Dr. Krantz, and they're both pretty short. For Dr. Simon, when you were looking at the results, did you notice any moderation with respects to the patient's household situation? My intuition would suggest that if someone lost their partner or their spouse and they were alone at home, that the grief would probably last a lot longer than if they lost their partner and their spouse, but they still had children to take care of, or even a dog. So did you notice, did you moderate for that at all?
So in the clinical trial, we didn't have a measure exactly of what you're talking about, but I would say in general what you're asking about is the presence of social support, which has been shown overall to be generally protective, but it usually, in the cases of people coming in with complicated grief, even when they have it, it's not been sufficient. So many of the people, actually, I didn't speak into too much great detail about the therapy, but many of the people we work with do have other people in their lives. They've just pulled back from them. So they have, as part of that kind of inhibition of exploration, being out in the world, have actually withdrawn, and the people around them have become very frustrated with them because they are no longer interacting or doing things with them or responding in the way. So part of what we actually do in the therapy is in the third session, we ask them to invite someone in to the session with them, in part to kind of reconnect and bring them into the experience that they have been working on, and also to help support them through the work, because often what they're hearing from those around them, all they're talking about is the loss, and others around them who may be close to them, and particularly if they're living in the same home. So if you think about, that death is affecting everyone in the family system, and different people have different coping styles, and those coping styles may be different. So it isn't necessarily just like the physical presence of a person. It depends on a lot of those factors. But enhancing the kind of effectiveness of that connection and social support is a very important outcome for people to do well. So it's a great question. Yeah.
Before you go on to your second question for Dr. Krantz, talking about the therapy, I'm just remembering, one of the questions I got during the coffee break was, could you unpack a little bit what were the elements of interpersonal therapy or motivational interviewing that was in the therapy that you were testing?
Looking around the room where the question was.
Oh, hi.
There have been a number of there's been a lot of work on therapy and intervention. Let me say first that the work on depression has probably been, from a therapeutic point of view, very disappointing. There's a consistent association between depression and cardiovascular disease, as I told you, but so far neither any behavioral or pharmacologic treatment has been able to break the association. In other words, the treatments are successful in lessening depression. The treatments are successful in improving quality of life. The treatments are not successful in terms of breaking the link between depression and coronary disease.
If I can answer also your.
Yeah, so it was, as you were bringing up the therapy you were testing, I was asked if I could bring up what were the elements of interpersonal therapy and motivational interviewing that you had incorporated into your intervention.
Oh, I see. So you're asking complicated grief, where I
In
said
complicated
that it was
grief
kind of, based on a bunch of different factors. Well, I think one of the things is just the concept of having people find meaning for themselves and reasons for change. Because as I was mentioning, often the patients come in and people have been just telling them to move on and move forward, and they're not able to do that. So helping them to identify kind of personal goals is part of the work that we do with them around the kind of life track, and then kind of integrating the issues around relationships is also part of that work, as I was talking about bringing somebody in and working with them around reconnecting when they've isolated themselves from others. So those are some of the factors that I guess are kind of built into those components. Yeah.
Yes, ma'am. Microphone coming down. Oh, did you give the microphone to someone already? Oh, okay. Right here, third row.
This is for Dr. Fenslow. Very interested by your work, and my question has to do with, sounds like there's two forms of fear learning, associative and non-associative. We can certainly understand the adaptive and survival significance of associative learning, but how would we explain stress-induced, or stress, whatever it's called, SEFL?
Yeah.
What's the adaptive survival significance to that?
You know, so adaptive survival significance is always a tough question to, to really know. You can make up sort of just so stories on it and say what the reason for it. There are two different ways to look at it. One is that you've had, the typical way to say is that you've had this very threatening experience, so now, because that has a potential to happen in the future, you want to be able to really quickly and strongly react to subsequent threats in the future. And that's a typical way, and it may be right. My speculation on this is a little different, and that is that these systems that evolved for fear learning are there for very potent, immediate problems. We're under a current threat, and we evolved to really deal with that threat quickly. And if we don't deal with it quickly, like we're being attacked by a predator or we're in combat situation, we're going to die. And so this is a system of paramount importance, and all your resources are dedicated for it, but it's meant to be for a very short duration. We've figured out ways to keep us in those situations far longer than we would ever evolve to be in them. And what you have is a breakdown in the system. The system was never designed to be stressed at that level for so long. And so now we're looking at the system has fallen into this aberrant pathway, and it's not really an evolutionary adaptation. It's because we've never evolved to deal with such threatening things for so long a period, and we're just good as humans of creating that kind of situation for ourselves. So it's not a functional thing. And that's, again, definitive answers are difficult when you ask these, long-term functional questions, but that's sort of my take on that.
Okay, thank you. I was thinking that there's this imprinting that is, the stressor is greater than what biologically we're used to having, and that seems to imprint on the brain. And there you go. Okay, thank you.
And then another question right over here.
So this one's for Dr. Fenslow, and that is also, so you talked a lot about the protein data and the product data. Do you have data also to support that there's transcription factors, or that there's epigenetic modifications that are going on that go along with it?
So all we've done is protein at this point. There's pretty new data that I was showing. So we haven't looked at transcription. We should do quantitative in situ and look at that. So I can't answer that question. I really feel that the answer is probably epigenetic, that this is such a long change in upregulation that there's probably an epigenetic change that serves this sort of thing. So I think that's one of the steps we'll take next, is to see what kind of epigenetic factors are maybe mediating this. But I think when you have that very long-term upregulation of a protein like that, it really cries out that there's some epigenetic regulation that's going on there.
Go ahead.
This question is for Dr. Fenslow. You mentioned with the cephalon that the post-training cephalon seems to be non-Hebbian, and you show that it seems to be specific where the training has to reoccur in context A. However, that retrained or that enhanced fear learning, does that show any enhanced generalization, or is that very specific to the retraining context as well?
So in terms of when we recephaled them, I think that that's going to be just a new instance of cephal, that it's going to generalize, again, not associatively across contexts like we saw the first time. I don't think there's any reason to think that it's different. I think the amygdala's gone back to its normal state here, but the amygdala can be thrown back into that pathology, right? So that, you know, we would have to treat again with antisense to get rid of the second bout of stress that would happen. I mean, that's my thoughts on that.
Yes, Dr. Asano.
Dr. Fenslow, one of the things I'm going to use you as is a lifeline. So Patcho was making a comment about integrating everything. And I was struck that, of course, we've heard about loss and bereavement, and we've heard in particular about anger. And the amygdala is not only responsive to fear. So might the mechanisms that you're unpacking be related to other stressor events, such as hostility experiences and also loss experiences? And there might be, the mechanisms might actually underlie more broadly some of our responses as well as our fear responses.
So, and that's, you know, a feeling that I think people often have, is that the amygdala is the fear center and that's just what it's doing. And that's really not true. You know, just as it does valence for fear, it does valence for positive reward and affect, and it's a much more general structure. And all these cells are mixed up together within the amygdala. So part of your answer is that the type of mechanism that I've looked at, you can well imagine if this GLUA1 upregulation is also happening in cells that serve positive reward, that's what leads you to drug addiction and all. And again, I'm speculating here. That's one of the things we want to look at, is are these other systems affected in similar ways? We don't know, but it would give us an explanation of those sorts of things. The other thing I want to say about, in terms of things like loss and these other types of stressors, psychosocial stressors, is that while I use a situation that produces pain, I don't think it's the pain that's the critical factor here. I think it's the psychological stress on the rat that really drives this. It's in this context for 90 minutes. It doesn't understand what a shock is. You give me a shock, I know what it is. It's not the same thing. It doesn't understand what the shock is. It doesn't know if this 90 minutes is the rest of its life or it's going to end now. And it's really the psychological stress that's happening there. And so that other mechanisms that you're talking about are just as likely to tap into these kinds of mechanisms. You know, I think don't emphasize, it's not the shock, it's not the pain. You know, if I feel that pain, it hurts me, it's not going to cause the same reaction in me as it does in the animal. So I really think it's, you know, your psychological state of not knowing the future of what's going to happen, not knowing what this means, what this is, that's taking the impact. And we just have to do it this way because we're dealing with a rodent, and we can control it very nicely in an experiment, but it's much more general to severe psychological stress, I think.
Yes, Dr. Fullerton.
What about the stress of knowing what it is? No one has talked really about age or the elderly, with knowing that a spouse is going to die being under the chronic stress of the last year of that. I'm not sure how to phrase the question. It seems to be one of these that could tie things together.
I think where to that. I think there's clearly effects of being under a chronic stress with anticipatory loss. But I think that would be the case even if you're not acknowledging that someone is going to die. So if you have you're talking really about kind of living under a situation of chronic stress. And so some portion of those people will become depressed or develop severe anxiety, insomnia, substance abuse, and all of those components are going to be risk factors then that will compound their ability to respond with an adaptive response after there's a major trauma like a death or a trauma that should follow. So I think maybe the model to think of is that's people who have been living under conditions of chronic stress proportion of them are likely to have developed some other of the conditions. So when I show data about pre-existing depression, anxiety, trauma, prior loss being risk factors, it's probably through some of these pathways of how that is affecting them and then their future ability. So if we kind of tie it together with they've had that non-associative stress kind of learning so that they're less able then to take another hit. But it's not necessarily that you've been exposed to the stress because many people adapt well to chronic stress and are resilient. In fact, the average is resilience, right? It's a small portion of people who then go on to develop significant mood, anxiety, other types of issues are those same ones who are going to be at greater risk again when they get the next hit of some major life event. So I think that might be a way to put some of what you're talking with.
If they're older, they might be more prone to having heart disease.
Carol, what I was thinking of was work that I saw many, many years ago that talked about the whole issue of expectedness, and that if an event happens, a life stage event happens to you early when you don't expect it, or later when you do, the fact that while biologically older people may be more frail, death of a spouse is more expected. If you look at somebody, and I don't know how this relates to the age association with complicated grief, whereas if you lose a spouse who's very young, it's devastating. Now it's very devastating to an older person too, but it's expected. So again, I don't know how that interacts.
Yeah, I mean, the one thing I would say, which is, I showed just a little bit of data to this, is once somebody does develop complicated grief, then in many ways the expectedness doesn't matter. So they can present equally, they experience it as unexpected. That was what I was trying to explain in some of my examples. Many of the patients experience it as if it was unexpected, and that's part of why they are stuck in having trouble processing it. So part of the answer to your question is that, some people successfully are kind of doing some of the work. We're working through some of this, and they're thinking about what they're able to think about, kind of their own life after the death of this person that is going to be coming when it's expected. But other people, it still comes as really a major surprise. And clinically, that was actually, for me, coming from more of a PTSD, anxiety background, it was something I had to learn, because I was sort of surprised to hear patients saying this over and over again, where it was so evident to everyone that their loved one was going to die. Yet to them, the experience was that they weren't ready. It was a surprise that it happened at that moment. They get very stuck on why did it happen at that moment. They thought they had another 2 months or another 2 years, or they hadn't been able to come to that place. And that's part of the work that we do, is getting them to be able to accept the reality and the permanence of that death. And some of that has to do with coping styles, avoidance, emotional avoidance, and so forth. But, yeah.
Yes, go ahead.
Hello. This is for Dr. Krantz on PTSD and cardiovascular disease. So when it comes to plaque ruptures and causing myocardial infarctions, I was wondering, just like in Cushing's syndrome, where there's an excess production of cortisol, it leads to thinning of the epithelial tissue. So I'm wondering if, because of PTSD causing a dysregulation of the HPA axis and causing this increase in excessive increase in cortisol, is this also causing a thinning of the cardiac muscle within the coronary arteries and causing this increased pressure on this weakening wall of the coronary artery to cause this plaque rupture to occur? Do you think?
You've asked an excellent question. I don't think there's an answer to it. Clearly, what it would involve, first of all, it's very difficult to measure stable and unstable plaque. There are methods now to do it. I don't think anyone's really asked that question. So, again, it's a good one in terms of identifying another possible mechanism for the link and the association.
Ma'am?
This is a question for Dr. Krantz. I was just curious about your thoughts on ischemic preconditioning as a viable treatment strategy or therapeutic for PTSD. Is there any data out there and any insight on the mechanism?
You know, I haven't seen work on a for that kind of study to be done. You'd have to look at something like myocardial ischemia, which is doable. I don't think anyone has applied any kind of physiologic intervention prior to ischemia as a way of breaking the link. So again, I hate to answer all these questions with regard to PTSD and say it's a great hypothesis, no one has looked at it. But again, most of the work in this area has been looking at associations. It's been epidemiologic work, relatively little on mechanisms. We know something about inflammation. We know something about some endocrine changes, certainly things like blood pressure, catecholamines, things of that sort. But we really don't know about the nitty-gritty at the cellular or molecular level in terms of ways of countering this.
Looking at FDR's blood pressure and the Better Heart study, do you see a role for the daily monitoring that's going on now? So people monitor their steps, their blood pressure, their heart rate. You can track your mood on different apps. Do you think there's a role for big data in a future study?
Well, I think there's a role for existing big data. I think that, for example, one study that was done looking at the Millennium Cohort group found, actually what they found was that combat experience was associated with increased risk of cardiovascular disease. There was a much weaker association of PTSD with cardiovascular disease. And again, they took the data from this large cohort of people. I think there are a lot of data out there that would be wonderful to exploit. You saw that kind of fortuitous study that I presented at the end with the PET scan, a brain PET scan, and then they obviously subsequently went back and looked at the data. I think that I think Bob's study with 1 million participants is a good data set to then do some follow-up in this particular area. I think that, again, to the extent that I don't want to say that it's not worth doing a study like this by itself, one of the approaches that people are using is something called ecological momentary assessment. I don't know if you're familiar with that phrase or what, but it basically means measuring activities, thoughts, emotions, etc. during daily life. So, for example, a lot of studies on antecedents of smoking behavior, and whether X, Y, and Z triggers smoking. Now, to the extent that one can look at some of these variables, antecedents that trigger them, that might be one kind of a route to go in. There have been studies, actually we did one years and years ago, which had patients keep diaries, and they had Holter monitors on, and we were looking for ST segment depression in conjunction with that Holter report of emotion. And we found a relationship, actually, of anger, but others have found similar emotion relationships with these physiologic events. So again, I'm sort of free associating on your question, and I don't know whether I'm answering it or not. But
All right, we'll take 2 more questions, and then we'll transition to the conclusion.
Okay, I'd like to ask this question to Dr. Fenslow. Since during the formation of association, the time period can be relatively short, like minutes or hours, a period of short-term potentiation, long-term potentiation of synaptic transmission. Can you completely dissociate or exclude the hippocampus from the involvement in stress formation learning?
Yeah, I think so. The clearest example in what I had talked about is when we gave that NMDA antagonist, we gave it to the hippocampus such that the hippocampus couldn't form a declarative memory, yet it allowed the sensitization to go completely on. So I think the hippocampus is not contributing to the non-associative part, at least the dorsal. Well, that manipulation would have hit most of the hippocampus. So yeah, I don't think the declarative memory part in the hippocampal memory system is critical for this. Now, when you look at something like a tone shock association, right, you can form an association within one trial, so very rapidly as well, where you're not using the hippocampus. So when you're talking about fear, it's also a very rapid learning system, but there can be implicit learning of fear just as rapidly as you have sort of an episodic memory form there. Is that?
Yeah, but there's also non-NMDA dependent learning.
True, yeah.
All right, and one final question.
Yeah, my question is to Dr. Fenslow. With your SCFL model paradigm, I wonder whether you can look at depression-like behavior as well, because there's a high comorbidity between depression and PTSD after stress, and your paradigm is somewhat similar to like learned helplessness, because since animals are passively receiving repeated shocks. So I was wondering whether you are able to see maybe in some animals, maybe you can see depression-like behavior, but in some animals you are more likely seeing, stress-enhanced fear learning. So whether you can study individual differences in, this paradigm.
So just 2 parts. I'm going to give a 2-part answer to it. We did look at the forced swim test, and we saw what looked like, a depressive phenotype on that. So that's, something that tends to correlate at least with antidepressant medications and all as an animal model of depression. So I think that we can pick up in our animals things that look like we're inducing a depressive-like state. The other part about individual differences is an interesting one, because in the preparation, the way I showed it to you, virtually all the animals, usually we do an experiment, 11 of 12 animals will show the phenotype, and might have one that doesn't. If we titrate the shock down and give instead 3 or 4 shocks, then we begin to see about 20% of the animals showing the phenotype. So I think we might be driving our animals pretty hard, and so we're converting a lot to the PTSD-like phenotype. Then also remember that our animals, they're much more homogeneous, right? So they're pretty genetically similar. They're outbred rats, but they're still quite genetically similar. They've had very similar environmental upbringing, so we might not expect the same variance we're going to see as we would have in the human population. But we haven't pushed the individual difference parts. We have the ability to do that, but we'd have to titrate this down to a smaller number of shocks, and then I think we'd be able to pull out individual differences. What would be nice that I haven't figured out to do is if we can somehow know who's going to convert and who's not without giving the additional stressor. That would be a great way to do that, but we're not there yet at that point. But we can move the paradigm to a point where we do see individual differences where only a portion of the animals do convert to that.
Thank you, everyone. Let's give our afternoon speakers one last round of applause.